All right, so I hope you can see the entire screen of my presentation. Okay, can you see my screen?
Yes.
All right, thank you. So we are going to discuss or to have a recap, the chemical chemistry course recap. For today, we are going to have the first part of it. And then tomorrow we will have the second part of clinical chemistry. So for today, as I've said, we'll be having the first part, which is general chemistry. We'll be discussing carbohydrates and protein. We'll be discussing enzymes, the clinical important enzymes. We'll be discussing lipids and the lipoprotein and proteins and amino acids. So then tomorrow we will have to cover the rest of chemistry, which is not usually known as the special chemistry. In the exam, we have it as a special chemistry. All right. So the first one as carbohydrates, as you know, carbohydrates. Carbohydrates are the energy source of the brain, the other cells of the body, including erythrocytes, and also, excuse me, let's get this one. Yeah. Yes. Yeah, and also other cells, the very active cells, including retinal cells, erythrocytes, of course, red blood cells. They depend on carbohydrates for their energy, as well as, of course, brain cells. But in that case, we cannot forget that there are diseases or disease process that involve carbohydrates, which can be divided into two types. We have hyperglycemic disease and also hypoglycemic conditions. So hyperglycemic condition is, of course, what is known as diabetes. And diabetes is a group of disease which is always characterized by hyperglycemia or high blood glucose. This diabetic itself or diabetes can be also divided into four parts or into four types. We have type 1, we have type 2, we have other specific types, and then we have the fourth type is known as gestational diabetes. So the four types exist, and those four types are types of diabetes. And so type 1, as you know, we can be able to distinguish or to differentiate these types basing on their etiology, or basing on their causes, or basing on their clinical manifestations and pathogenesis. So type 1 is when you want to explain type 1 diabetes or type 1 diabetes, you always don't forget autoimmune destruction or autoimmune disorder or autoimmune involvement. And autoimmune disorder involves the pancreatic B cell or beta cells or beta islet cells of the pancreas, which are destroyed by autoimmune antibodies or autoantibodies, and this leads to absolute insulin deficiency. So that's the cause of absolute insulin deficiency, where type 2 does not involve absolute insulin deficiency, but involves insulin resistance or any other problem, but is not actually deficiency of insulin. So the markers of lab markers that we are going to identify in type 1, of course, will be the islet cells, autoantibodies, and insulin autoantibodies. And also this also involves diabetes ketoacidosis, or keto antibodies are also seen, or they are prominent lab markers in type 1 diabetes mellitus. So we identified these antibodies. Of course, you remember, okay, some of you have not yet covered immunology, but you remember in immunology, we also study autoimmune disorders, where we discuss all these autoantibodies and their way of testing. Of course, most of them are antinuclear antibodies, but these autoantibodies against pancreas, they are not antinuclear antibodies, but they are also tested as the autoantibodies in which also involve in immunological processes. So the result, of course, will be destruction of the cells, the pancreas, which are responsible for insulin production, and this causes absolute insulin deficiency. So apart from that, the type 1, type 2 is a bit different, and type 2 just is characterized by resistance and the secretory defects, which leads to hyperosmolar coma and no keto acids. So what happens is that there can be two things. There can be insulin resistance, or there can be secretory defects. Secretory defects, sometimes the insulin is abnormal. The insulin that is produced is abnormal, or it can be resistance. Which resistance are we talking about? Resistance is that insulin is not able to bind to the receptors, because insulin is not just moving. It is going to target cellular receptors that are able to bind insulin in order to stimulate internalization of glucose, of sugar. So with that kind of resistance, insulin will not be able to bind to those receptors, and of course sugar will not be internalized, or will not be used or captured by the cells. And which, of course, when glucose is going to accumulate, too much glucose will lead to hyperosmolar coma, which means that the person will be into coma because of hyperosmolarity, or because of high osmolarity of blood, which is because of, glucose also can increase osmolarity of blood. Though, of course, osmolarity is usually attributed to sodium chloride or salt. In fact, also glucose contributes much to this osmolarity. So this person will suffer hyperosmolarity or hyperosmolar coma, but usually no keto acids, because of course during that time the insulin is there, so there will not be a production of glucagon. Glucagon is the one that stimulate the what we call lipolysis. Lipolysis is stimulated by glucagon, and lipolysis
started the guide. Remember I was telling that they'll come back to us. There's a project.
Any question? Please try to mute your microphone. Try to mute your microphone in order to avoid distraction. So other specific types of diabetes include diabetes secondary to genetic defects, for example, sometimes pancreatic diseases, sometimes drugs. All of these can cause other specific types of diabetes. So this is just a diabetes that happens or that occur because of specific conditions, but not really among the two types, or the fourth one you are going to see, but it happens because of a certain specific condition. For example, we have said pancreatic disease or pancreatitis can also lead to diabetes, but it is different from type 1 because type 1 is autoimmune pancreatitis. So the one that we call GDM is the fourth one. GDM, it is gestational diabetes mellitus. This is always confirmed at least in the second or the third trimester, and when a pregnant woman has is diagnosed of diabetes in the first trimester, that diabetes is
sorry to
not
interrupt you.
gestational diabetes, and that one is
Teacher,
called
please.
overt. Yes, please.
You can help people. Many people are just claiming out in WhatsApp. They're not able to join. Please help.
No. It's not that. It's not my problem, because the ones who are joining, I'm admitting them. And there's no one pending in the room. No one pending in the room. Yeah, sorry for that, because I actually don't know why they're not able to join, and you guys are here, and no one is pending in the room. Maybe it's because the first time we are using the Zoom. So yeah, because yeah, I've already shared the ID, and no one is actually no one is pending. And anyone who want to join in the room, I'm able to see the message coming to me that I have to admit someone, and I'm admitting. Sorry for that. Maybe we'll get used to it. Yeah, they are still coming anyways. So maybe those ones are still coming in, and I will be admitting as they come. No problem. Okay, thank you. So the fourth one, which is gestational diabetes mellitus, this is just, as I've said, this type of diabetes mellitus is not diagnosed in the first trimester. If it is diagnosed in the first trimester, this mother, we don't confirm, we don't report gestational diabetes mellitus. This must be diagnosed in at least in the second trimester or in the third trimester. Okay, this is when we can confirm this gestational diabetes mellitus, and this is always diagnosed when there is what we call glucose intolerance. And how do we know there is a glucose intolerance? It is when we perform oral glucose test, or oral gestational glucose tolerance test. So when we perform that, then we can confirm from the findings that I'm going to show you that helps us to confirm his gestational diabetes mellitus and also other types of diabetes. So in general, the criteria for diabetes mellitus, when you have results and when you want to interpret the result, in order to know that this patient is suffering from this condition, so you have to confirm HbA1c, which is a glycated hemoglobin A1c. This type of hemoglobin that is glycated or conjugated with glucose, and you have to confirm at least greater than or equal to 6.5%. So this is the portion or a percentage of HbA1c or conjugated hemoglobin with the glucose. So it should be at least greater than or equal to 6.5%. That can confirm diabetes mellitus. And then we can also use this second criterion, which is fasting plasma glucose of at least 126 and above. 126 and above milligram per deciliter, or usually when you're using millimole per liter, it will be 7 millimole per liter, and this can also help you to confirm or to diagnose diabetes mellitus. And we can also diagnose diabetes mellitus by using 2-hour plasma glucose oral glucose tolerance test, or OGTT, which should be at least when it stays beyond 200 after giving 75 grams of glucose, oral glucose, after fasting, of course, and then after 2 hours you measure 200 or above milligram per deciliter. So this is going also to help you confirm or diagnose diabetes mellitus. Then also random plasma glucose. Random plasma glucose, which is also greater than 200 milligram per deciliter. But of course, this must be accompanied by symptoms. Without symptoms, you don't confirm diabetes without symptoms. When the sugar that is measured is a random plasma glucose. So you never confirm that, except when there are also accompanying symptoms of diabetes. So a confirmation requires a subsequent day. So you need to confirm on the subsequent day, not just on the single day. You need to confirm on the subsequent day. So you don't need also point of care for this diagnosis. No point of care, no rapid test, no glucometer in this type of diagnosis. This is general diagnostic criteria for diabetes mellitus. So let's see criteria for prediabetes and general diabetes. Of course, the prediabetes, which criteria for prediabetes? Because we also have what we call prediabetic condition. This is the person who is between normal person and diabetic person. So the person is not diabetic, but also the person is approaching this high level of diabetic sugar. This person, everyone who is above 45 years of age should be tested at least every 3 years in order to confirm this possibility before we can diagnose diabetes. Fasting glucose when it is above 100, but not up to, not beyond 126 or 126. It should be less than this, but greater than 100. This is always, this can confirm the prediabetes. And when there is also impairment of glucose tolerance, which means that 2-hour oral glucose tolerance test is giving at least 140 and above, but not up to 200. You know that 200 is a confirmatory result for diabetes. But when it is not up to 200, but it is beyond 140, after giving 75 grams of glucose orally, and you measure glucose in 2 hours or at 2 hours, so that can show that the patient is just flagging that the patient is, or the individual is in the state of prediabetes. And also the same thing that 5.7% and 6.4%, which indicates the prediabetes condition as well when we use the parameter of glycated hemoglobin. So now, finally, how do we diagnose gestational diabetes? Now, the gestational diabetes is measured in what we call two-step approach. We can use one-step approach, or we can use a two-step approach. And how do we do one-step or two-step approach? So the one-step approach is a very simple one, where you have to do 75 glucose load. That is the normal approach, the normal glucose tolerance test that we do. 2-hour OGTT of 75 grams of glucose load. So this is one-step approach for gestational diabetes. So if you do this one-step approach of 75 grams, and before you perform that, of course, you have to make sure that the mother is in fasting state of at least 8 hours, but not exceeding 16 hours, okay? And when you do that, you have to, first of all, measure the baseline glucose, that fasting glucose. When it is greater than or equal to 72 milligram per deciliter, and then you record this number, and after giving 2 hour, giving 75 grams, you measure at the first hour, not at the second hour. You measure at the first hour, and the value that is beyond 180 milligram per deciliter. Okay, and then the second measurement, which is 2-hour glucose value, which is beyond 153. So this is diagnostic of glucose of gestational diabetes mellitus. If any of the 3 criteria are met, any of the 3 criteria, it can be fasting glucose of 92, it can be 1-hour value of 180, it can be also 2-hour value of 153. Any of them can confirm gestational diabetes mellitus. So this is when you choose to use one-step approach, but you can also use what you call two-step approach. A two-step approach is also used where you use the first step, or you can, it is like divided into 2 steps. This one is sorry sorry for that. Let me go back to okay, yes, we are here. Okay, so this, which is the two-step approach, you first of all give 50 grams of glucose load, 50 grams, not 75 grams. And then if a plasma glucose value is greater than or equal to 140, after 1 hour, this is after 1 hour, you just test, you just measure glucose after 1 hour, after giving 50 grams. After 1 hour, glucose is showing is 140 and above. This indicates the need to perform 3-hour oral glucose tolerance test. So which means in the two-step approach, you don't confirm from one only or from the first step, which is 50. So what it helps you is that it is going to show you the need to perform 3-hour glucose tolerance test, which you use to confirm the gestational diabetes mellitus. So what happens is that you ask the patient to fast again, because you don't do it at the same day. On the same day, you ask the patient to fast again at least 10 hours, and you measure fasting glucose. And when you get above 95 milligram per deciliter, then you measure 1 hour, which would be beyond 180, and the second hour, which is beyond 155, and the third hour, which would be beyond 140 milligram per deciliter. So any of these is going to confirm also the gestational diabetes mellitus. So that is how you do the workup, or the protocol for gestational diabetes mellitus diagnosis. Okay, so these values could be somehow difficult to memorize, but yeah, sometimes you would find that you may need to have in mind which value correspond to which diagnosis. That is very important. So then let's continue to the next slide, which now talks about the fructosamine. Fructosamine is like HbA1c, or glycated hemoglobin. This is not glycated hemoglobin, but fructosamine is when glucose binds to albumin. The glucose to albumin. This also increases when glucose increases in plasma, and it is sustainable. It is not that you are going to consume a lot of sugary food and fructosamine increases, doesn't. But this one is when glucose is steady in blood or in plasma. So fructosamine is when albumin carries some molecules of glucose, and this increase with the increase of glucose in plasma. And this can be a very reliable parameter to diagnose diabetes, or to monitor diabetes treatment or monitoring of treatment, because it can measure average glucose over 2 to 3 weeks. You know that HbA1c, it is measuring at least 2 to 3 months because of the lifespan of red blood cells. So this can be the best, it can be better tool, diagnostic tool for glucose, or monitoring tool for glucose over a short period of time, like 2 weeks, because you know that HbA1c cannot be used for this short period of time. So hypoglycemia is another disorder, or is another abnormality, of course, where we start talking of hypoglycemia when glucose is very low, to 50 to 55 milligram per deciliter. This is where symptoms, hypoglycemic symptoms appear, and the symptom, the person is diagnosed of hypoglycemia when the person is showing a triad of these criteria. The first one, the person should show hypoglycemic symptoms. The second, this person should have low glucose levels, which should be less than 50 milligram per deciliter, and the person should be relieved when glucose is administered. Here you can also add glucagon. When glucagon or when glucose is administered, this person must be relieved. There must be a relief. So without relief, then this is not hypoglycemia. Hypoglycemia happens as a condition, but which must be relieved when glucose is administered. So now, finally, what are the methods of glucose measurement? So these just are some of the methods that we use to measure glucose. Of course, you know, in lab, we use some specific methods. Some of them are not specific, are not very good. Some of them are not good at measuring the amount or to quantitate. So, for example, like using Benedict's or Fehring test. The two tests just based on the principle of copper reduction, and that's what you call reducing sugar measurement. Reducing sugars, reducing sugar measurement. This is when the reducing sugars like these monosaccharides like glucose can reduce copper to iron, which is usually copper sulfate. Copper sulfate is found in Fehring reagents, even in Benedict reagents. Copper sulfate, we call it copper sulfate pentahydrate, which is actually converted into copper oxide. So copper oxide in the presence of alkaline condition. So the alkaline condition, which is brought by the presence of sodium hydroxide in that system, or in that similar solution, because we are testing. So the presence of sodium hydroxide brings about this alkaline condition. So there is a formation of reddish brown precipitate because of the production of copper dioxide, and that is a confirmatory of the presence of reducing sugar like glucose. But of course, this can be analyzed by colorimeter. So sometimes, but we have now more advanced techniques nowadays we are using, like glucose oxidase and glucose hexokinase. So glucose oxidase, which is very specific for beta D glucose, but also alpha D glucose is also measured, but it must be converted first. The enzyme that converts alpha D glucose to beta D glucose, so the beta D glucose is the one that is converted. It is actually oxidized, because glucose oxidase is an oxidizing enzyme which oxidizes glucose to gluconic acid. And during this process, of course, oxygen is going to be consumed. And when glucose is consumed, there will be production of hydrogen peroxide. So in this case, hydrogen peroxide is produced, and hydrogen peroxide will oxidize a chromogen, what we call a dye, using another enzyme, which is a horseradish peroxidase, that is going to help or to facilitate this action of hydrogen peroxide oxidizing a dye or a chromogen. So then we can be able to measure what? The presence of color by spectrophotometer, or we can be able to measure the rate of disappearance of oxygen using oxygen electrode. That is also done. So that is, it depends on which principle that your machine is using or is employing. Okay. So this, the second one, it is known as hexokinase, which is the best one because hexokinase doesn't have any interference. You know, glucose oxidase can be interfered by many interferences, including ascorbic acid. Ascorbic acid can interfere because ascorbic acid can interfere with chromogen conversion by hydrogen peroxide. That's one of the interference. But hexokinase is very specific for glucose because, you know, hexokinase is enzyme that uses ATP to phosphorylate glucose, which is known as hexokinase. Kinase is an enzyme that phosphorylates. That's the meaning of kinase. So it phosphorylates hexose sugar. That's why it is known as hexokinase. Hexokinase 1, which phosphorylates glucose, and it becomes glucose 6-phosphate, and then glucose 6-phosphate is then also phosphorylated by is oxidized by another enzyme which is known as glucose 6-phosphate dehydrogenase. So the dehydrogenase is just to remove hydrogen, but also it is another way of oxidation. So where glucose is taken by NAD plus or nicotinamide adenine dinucleotide oxidized, and then it is going to be reduced like this, NADH. NADH is going to bring about color formation, and then absorbance will be achieved. So the rate or the higher the formation of NADH, the higher concentration of oxygen, of glucose. That's what happens. So what is measured is NADPH formation, is not 6-phosphogluconate. So that is the principle. That's how hexokinase works in measurement of glucose. Now, let's look at the second part of our plan, which is lipids and lipoproteins. So lipids are just, lipoproteins are just, you know, we have two terms. We have one term that is called lipids, and the second term is called lipoproteins. So lipoproteins are just things or molecules that are made up of lipids and proteins. Okay, and they carry out various functions in the body as the carriers or cargo. We can call it cargo, or can call them what? Truck that carry like lipids or triglycerides or cholesterols. So they are known as lipoproteins. So lipoproteins is because of their structure. So because of their structure, because they possess the internal core, their core surface, their core area contains triglycerides and cholesterols, whereas their outer shell surfaces or surface is now made up of proteins, which help them to interact with environment. Because our body is not hydrophobic, you know, our body is hydrophilic. So otherwise they cannot be able to move or to interact without these apolipoproteins, which are known as surface proteins. So we have 4 types of lipoproteins. We have chylomicrons, we have very low density lipoproteins, we have low density lipoproteins, and we have high density lipoproteins. So the 4 lipoproteins exist, and what is their function, and how do they come to our discussion? What is their clinical significance? Because here we're talking about clinical significance of everything we are discussing here. Okay. All right. Okay. Now I've been admitting our members. I know because today is the first class where we are using the Zoom. I don't blame anyone because Zoom can be challenging when you are using it for the first time. It can be very challenging. But tomorrow we'll be used to that because we are going to use Zoom. We are not going to use the Google Meet anymore. So I have to be familiar with this because Zoom provides. We have an account on Zoom. We have a license. We have a license on Zoom, which we purchased. So we have to use it because it provides various features that we need in our learning process, including, of course, the high definition video recording, which we are doing now. Okay, so these are the four major types of lipoproteins, and this is the structure of proteins. You can see the outer layers. We have phospholipids, we have transmembrane proteins, and we have these core proteins known as not transmembrane. This is not a cell. We have core protein, surface proteins. Which is known as apolipoprotein. Okay, so apolipoproteins and lipoproteins. What a difference! As I've said, apolipoprotein are types of proteins that are contained in the lipoproteins. So the apolipoproteins, we have two major types. We have ApoA and ApoB. So ApoA is the major apolipoprotein in high density lipoproteins, whereas ApoB is a key apo in LDL and VLDL and chylomicrons. So you can see we have ApoA. ApoA is only found in high density lipoprotein. So that is also what we call ApoA, ApoA or alpha apolipoprotein because of the A. So then the B is beta. Okay, so ApoBeta is found in low density, very low density, and even chylomicrons, whereas ApoA or ApoA is found mostly in high density lipoproteins. So ApoB now exists in two forms. ApoA is one form. Okay, ApoB exists in two forms. The first form is ApoB 100, then the second form is ApoB 48. ApoB 100 is found mostly in low density and very low density lipoproteins, whereas ApoB 48 is found in chylomicrons. And ApoE also exists, but ApoE is somehow shared. ApoE is shared among many lipoproteins because ApoE has got a very serious importance in this process because ApoE are like receptors to the liver, because the liver has to uptake or has to capture the lipoproteins when they are like remnant, when they finish their activity, they have to be uptaken by the liver. So when the liver will use the receptors which will recognize ApoE, so which means that ApoE is a protein but is a receptor which facilitates the uptake of these lipoproteins when they finish their activity. So they have to go back to the liver. So now, what is chylomicrons? Chylomicron now, what the function is to deliver dietary fats from the intestine to the tissues of the body. dietary fats, like chylomicron is packed with dietary triglycerides, food. Okay, then they are transported into the tissues of the body. Then they are left there. Because you remember that chylomicron is not digested. I mean, is not uptaken, is not taken by the cells. It's just like the river. It's like offload. No? It offloads when it reaches tissues. Then when it offloads triglyceride, it becomes shrinked. It shrinks. Then that's what you call remnant, chylomicron remnant. That is what now has to travel to the liver, and it is destroyed by the liver itself. That's what you call exogenous transport of triglycerides, or exogenous fat transportation. Then we have the second one, which is called very low density lipoprotein, which carry liver-made fats to other tissues during fasting period. When someone is fasting, how do you get lipids in your body? When you are fasting, because you are not eating, how do you get triglycerides in your body? What happens is that now the liver manufacture lipids, and then they are packed in very low density lipoprotein, and they have to be transported to the tissues of the body when someone is in fasting state. That's what you call VLDL. And the third one is low density lipoproteins. This one has to carry cholesterol to the body cell. Mostly is cholesterol. I've been talking about fats or triglycerides, but here LDL, we are talking about mostly cholesterol. It is packed with too much of cholesterol, which is carried to the body cells. So then we have the last one, which is high density lipoprotein, which in fact collect extra cholesterol from the tissues and then reverse transport them back to the liver. When there is excess cholesterol in tissues or in blood vessels, this HDL corrects them and they pack them and transport them back to the liver. So that's the function of each of these lipoproteins. Now, what is a characteristic? And this is what you should also remember. Characteristic of these lipoproteins in blood or in sample. Chylomicron, it is able to scatter light because chylomicron is very light. It's not dense. Why is it light? It's because it is packed. It is packed with triglycerides, which is fat. Fat is not heavy, but it contains very little amount of proteins. So that's why it is very light. It's not dense. So it's low density. It is very low density. It is not dense. Huh? So when someone after meal, after eating, after what we call postprandial plasma, when you collect blood after the patient has eaten, you will notice that the plasma will have milky appearance. So that milky appearance is because of this chylomicron in that plasma. So it also scatters light, and after storage at 4 degrees, it can form a creamy layer on top of plasma. You will see when you store blood in the fridge, especially when you store like, usually we used to store ADTA blood, maybe for test. Sometimes you find that after storage, tomorrow, there's a creamy layer on top. So it means that that blood was collected after meal, or postprandial. So very low density, it is also very low. The density is very low, but it is active in a fasting state. And we have said that very low density lipoprotein is manufactured in the liver and is packed with the cholesterol or with lipids, fats that are made in the liver, what you call endogenous fats or endogenous lipids. So this one are packed in very low density lipoprotein. And sometimes after fasting states, when you collect blood also, if someone is fasting, you notice that this person is also having plasma that is very turbid. Turbidity of plasma is because of the presence of very low density lipoprotein, plasma turbidity. Okay, But this also, it is very small. It is very dense. I mean, it is very light, but it is very light, very large, but smaller than chylomicrons. So it doesn't form a creamy layer on top of plasma after storage. So this can be a differentiating clue. Okay. So because very low density lipoprotein is going to be destroyed by the liver, and the next product is called intermediate density lipoprotein, which is a transient lipoprotein, and it has to be transient. But if someone is suffering from what you call type 3 hyperlipoproteinemia, this intermediate density will be very high abnormally, okay? And if it is very high abnormally, so it means that this person is lacking what? The person is lacking ApoE. You remember what we explained about ApoE? We said that ApoE is a protein, is a protein that serves as a receptor for these lipoproteins to be accepted by the liver for metabolism. So when someone doesn't have ApoE, or they have deficiency or faulty, so it means that intermediate density will not be digested, or will not be absorbed by the liver, and it will remain in blood. And that's what you call type 3 hypolipoproteinemia. Okay, now low density lipoprotein, now it contains ApoB100 and with high cholesterol levels. ApoB100, you know, and an intermediate density lipoprotein is the function is to deliver 2 types of cholesterols. You know, we are coming back to cholesterol, not triglycerides. It can deliver exogenous cholesterol, or it can deliver endogenous cholesterol. Exogenous cholesterol, this is cholesterol that is from food, dietary cholesterol, whereas endogenous, of course, is that cholesterol that is made or produced in the liver. And then finally, we have high density lipoprotein, which is the smallest and most dense lipoprotein among others. And this one, you know, it is responsible for reverse transportation. And I hope we have already described 4 types of pathways. We have endogenous, we have exogenous, we have endogenous, we have reverse types of lipids transportation or mechanisms. So now this one now serves in reverse transport of especially cholesterol from the body, excessive cholesterol back to the liver for metabolism. So now, finally, what are the conditions of lipids? Those conditions are known as dyslipidemias. So dyslipidemias are also divided into 2 parts. We have hyperlipoproteinemia and hypolipoproteinemias. So also hyperlipoproteinemia is also subdivided into hypercholesteremia, hypertriglyceridemia, and combined hyperlipidemia. These are the 3 parts or the 3 categories of hyperlipoproteinemias. So hypercholesteremia doesn't mean cholesterol. It means that the person has very high low density lipoprotein. That's what you call hypercholesteremia. So it is usually because of low density protein doesn't have receptors, active receptors, or the ApoE is defective. When ApoE is defective, also this person can suffer hypercholesteremia because LDL is not metabolized, but also the peripheral cells don't possess active receptors for low density lipoproteins. That's why, you know, what I've explained about chylomicrons. Chylomicrons are not they are not metabolized by the cells. What they do, they just offload their products and go. But LDL are taken. If they bring cholesterol, they are metabolized. I mean, they are taken, they are consumed along with their cholesterol. So because of that, they require receptors to the peripheral cells. If the receptors are not active, then these LDL will be wandering around, will be moving around in blood. That's what you call hypercholesteremia. Then we have also what you call hypertriglyceridemia, which is also imbalance between synthesis and clearance of very low density lipoprotein in blood. And then finally, we have what we call combined hyperlipidemia, which is elevation of total cholesterol and total triglycerides, total triglycerides and total cholesterol. When both of them are high, then we call it combined hyperlipidemia. Now, then we have conditions associated with a very low lipoproteinemia, where there is a disease. Of course, you have, it is also important also to have enough lipids, if I can say, enough lipids in blood, in body. So even someone with low lipoproteins, like for example, if someone has very low density lipoprotein, it is also a problem. This is also a problem, and what happens is that there will be impairment of fat soluble vitamin absorption. This is also a condition. It is a disease. If someone has very low density lipoprotein, so this person is also having defective or impairment in fat soluble vitamin absorption. And then we have alpha. Remember what we call the alpha. Alpha is ApoA, and you know ApoA is found in high density lipoprotein. So when someone has absolute or severe form of hypoalpha lipoproteinemia, the condition is known as Tangier disease, and that is when HDL is very low, as low as 1 to 2 milligram per deciliter. Now, finally, let's look at the cholesterol and triglyceride measurements. How do we measure them? So first of all, of course, you have to understand these processes where when you want to measure cholesterol, because cholesterol is not there as a free cholesterol. Usually, it is conjugated. It is a polymer. Do we call it a polymer? It is a long chain. It is a long chain of cholesterol, which you call cholesterol esters. So these cholesterol esters are types of cholesterol that, of course, that are combined together. So what happens is that there must be enzyme which is known as cholesterol esterase, which break down cholesterol using water. That's what you call, that's like hydrolysis. And then there will be free cholesterol and fatty acid. Then cholesterol is then oxidized by the cholesterol oxidase, and then there will be production of hydrogen peroxide. Hydrogen peroxide, what happens is that always when hydrogen peroxide is the product, we have to use chromogen. We have many chromogens we use that can be oxidized by hydrogen peroxide in order to produce a color using peroxidase. The same like other like glucose, for example, glucose oxidase. That's what we saw. Then we have also measurement of triglycerides. The same thing, but a bit different, but they have to come to the same end. Triglyceride is broken down by lipase. You know, lipase enzyme that can break down triglyceride into fatty acid and glycerol. And what we need is glycerol. Glycerol is going to be also phosphorylated, and then it becomes glycerophosphate. And then glycerophosphate is oxidized. It will be oxidized and the production of hydrogen peroxide. And this similar process as cholesterol would happen. Hydrogen peroxide will oxidize a chromogen, what you call a dye. This is a colorless compound which will be oxidized by hydrogen peroxide to produce a color. and that color is measured. And what happens, all of them are measured using a spectrophotometer because of absorbance capacity of this color formation. Then we have this formula. You know, this formula, it is used in some labs, but not in many labs. But of course, you know that we have to obtain total cholesterol, HDL, and triglycerides in order to calculate low density lipoprotein using this formula that you see here. Okay. Now, the final part of this presentation is enzyme of clinical significance. So you know we have various enzymes, but we have selected very key enzymes in exam. Of course, those ones that are also a bit complicated. Otherwise, we have other enzymes like AST, LT, LP, GGT, amylase, lipase. Those ones, they are common enzymes that we know. So, in fact, first of all, enzyme kinetic is very important. Enzyme kinetics, enzyme is, of course, a molecule, is an enhancer, is a molecule that lower what you call activation energy level. Activation energy level is the energy that we push formation of products. That is the energy that must be possessed by substrate or reactant in order to bring about reaction. That's what we call activation energy. So in this case, enzyme is there in order to minimize the requirement of activation energy. So that's why enzyme is not consumed. It's just there to facilitate. It's not consumed. It's not a reactant. So factor that influence this reaction of enzyme is that there are different ones. For example, what you call first order kinetics, zero order kinetics, enzyme concentration, temperature, and so on. Let's see what is called first order kinetics. First order kinetics is when the rate of reaction is directly proportional to the substrate concentration. That is when the formation of products is moving proportionally to the substrate concentration. So that's when you have enough amount of enzymes in the system, but you are adding substrate slowly. When you are adding substrate slowly and the formation of product occurs, that's what you call first order kinetics. Okay, so now what you call zero order kinetics. What is zero order kinetics? Zero order kinetics is when now you have been adding so many substrates, but now all enzymes are saturated. Now there is a formation of products. If products are being formed, some enzymes are being freed. Enzymes are free now from that reaction because product is being formed. And if a product is formed, there would be free enzymes. So because substrates are now too much, enzymes now that are being formed are being liberated from the product formed. They are also coming back and react with excess substrate. That's what we call zero order kinetics. I hope that one is clear. Isn't it? Is that clear? First order and zero order. First order is when we have enough enzymes and we are adding substrate slowly and there is formation of products. That is when you see a slope. But when now there is what you call maximum velocity or maximum reaction, there would be no free enzyme again to react with the excess substrate being added. Then what will happen? Substrate are many, enzymes are exhausted. What happens is that products are being formed. By forming products, some enzymes are being released from that, and those enzymes will come back and react with substrate excess and form new other products. So that's what you call zero order kinetics. So now that's how it is. Okay, then we have enzyme concentration. What is enzyme concentration? That is when substrate is greater than enzyme. Okay, the velocity is proportional to the enzyme concentration. That is, when enzyme is high. For example, enzyme is for example, when enzyme is high, substrate is being added. The velocity depends on the substrate. But when now substrate have already saturated all enzymes, or they are higher than enzymes in the reaction, so it means that these enzymes, this reaction is going to depend on what? Is going to depend on the enzyme concentration, because now substrate now is exceeding the level of enzyme, which we call zero order kinetics. Okay, temperature is also then another factor that influence that. So you know that temperature also, temperature, when you are adding temperature, as you add 10 degrees, the rate of reaction is being doubled until the protein is denatured, until enzymes are denatured. When you reach around 45 to 50 temperature degrees Celsius, enzymes are destroyed. So now we have also inhibitors. Inhibitors are also other factors that influence the function of enzymes. Inhibitors, we have three types of inhibitors. We have what we call competitive inhibitors or competitive inhibition. This is when substrate and inhibitors are binding at the same site. So there will be inhibition. When you increase the substrate concentration, then inhibition is reversible because you are increasing substrate and there is competition. So then it means when substrate are more than inhibitors, substrate will be favored and substrate will compete them, and then this inhibition can be reversible. So, but when it is non-competitive inhibitor, it means that there is no competition. So it means that inhibitors are binding on the other sites other than the site of enzyme. I mean the site of substrate or substrate sites. So competitors are binding on the other side behind. So if those competitors are binding on the other side, so there's no competition. So whether you increase concentration or not, this will not be reversible, because what is happening is that substrates are bound and inhibitors are bound, but different sites. So increasing one of them, there will not be any change. Then we have anti-competitive inhibitors. This is where inhibitor binds enzyme substrate complex, and this is going to cause what? It's going, when you increase substrate, you are increasing complex, and when you increase enzyme substrate complex, you are also increasing inhibition. So that's a problem. When there is any competition or any competitive, it means that inhibitor is not binding enzyme alone. Inhibitor is binding enzyme substrate complex, and when you increase substrate, you are even increasing the formation of enzyme substrate complex by also increasing inhibition. Now, some of the very important enzyme of clinical significance. For example, we have creatine kinase, the CK. The creatine kinase involves in ATP production in muscle, in muscle tissues, ATP production, and creatine phosphate. What happens that creatine phosphate is broken down into creatine, and the creatine would be formed from creatine phosphate, and also the formation of ATP as energy. That's what happens. That's the function of creatine kinase. Creatine kinase now has got 3 isoenzymes. The first one is called CKBB, or creatine phosphate brain type. This, which is which is normally high, it increases in extensive damage to the brain and some carcinomas. Okay, like for example, prostate cancer, this CKBB is increased. CKMB also, which is known as hybrid type, it is muscle and brain. That's why it is known as MB. It is usually a marker of myocardial infarction or myocardial damage. When it is high in blood, it shows myocardial infarction. And then you have CKMM, which is a marker of muscular dystrophy. It means damage to the muscles. So like skeletal muscles, yes, that will, in fact, and the other muscles, that will actually increase this CKMM, which is known as muscle type. So the second important enzyme is lactic dehydrogenase, lactic acid dehydrogenase, or lactate dehydrogenase, or LDH. LDH, it involves the body in the conversion of lactic and pyloric acid and then reduce NAD+. This is the function. For example, lactic acid can be converted to pyruvate and NADH is reduced, yes, from these oxidation states of it. So what is the clinical significance? Clinical significance of this is that in a normal serum, we have 5 major isoenzymes. But this is what we see in a normal serum, 5 major isoenzymes. One is called LDH2, which is the highest, followed by LDH1, LDH3, LDH4, and finally LDH5. So when someone is suffering cardiac damage, for example, cardiac damage, this LDH2, which was highest, will no longer be highest, but LDH1 will be higher than LDH2. If this one happens, is what is known as LDH flipped pattern. LDH flipped pattern. That's when LDH1 is higher than LDH2, and this happens. When this one happens, this can be suggestive of cardiac necrosis or acute myocardial infarction or intravascular hemolysis, because also LDH1 is high in red blood cells. So, and if this one happens, of course, it is suggestive of what? Acute myocardial infarction. Now we have LDH2. LDH2 is increased in case of acute renal infarction, megaloblastic anemia, and hemorrhagized specimen. Thus, LDH will also be high. LDH3 is usually high in pulmonary disorders and carcinomas, whereas LDH4 is significantly increased in hepatic injury and various inflammation. And LDH5 is significant, elevated in hepatic disorders and intrahepatic disorders, for example, some hepatic disorders like hepatitis, and also muscular dystrophy. If someone is having muscular damages, there would be also high lactate acid dehydrogenase 5 isoenzyme elevated. So there is also another abnormal ADH. ADH, which is abnormal, is known as ADH6. ADH6 is not normal in a normal serum, and is what we call alcohol dehydrogenase. And alcohol dehydrogenase, in fact, has been present in patients with atherosclerotic cardiovascular failure. Atherosclerotic cardiovascular failure. This is a very critical issue. This is when someone is having atherosclerosis, which causes cardiovascular failure or vessels and cardiac failure, and its appearance now signify a grave prognosis and impending death. If someone is having this, it means that this person is actually going to die. This is a grave prognosis. It is not a bad prognosis. but it is a grave prognosis, which also shows impending death. So now we have ADH5. ADH5, in fact, when ADH5 is concurrently elevated together with ADH6, it means this person is suffering from hepatic congestion because of cardiovascular diseases. Yes, that is a problem also. If someone is having cardiovascular problem, for example, cardiovascular failure, and is having hepatic congestion because liver is not being supplied by enough blood, and both ADH5 and ADH6 will be elevated. So that's what happens in these isoenzymes of LDH. Thank you so much. Thank you so much. This is what we are able to prepare for you today. I'm hoping that tomorrow I will be able to make the rest of clinical chemistry, and then we proceed with our next course, which is laboratory operations. So sometimes I'm very busy, because you know that we have our members of class who are joining, and of course we have to admit them and assist them and enjoy together this company as we learn. So thank you so much for your time. I appreciate, and feel free to ask any question you may have. Yeah, this was just a class of those who attended clinical chemistry. It was just to revise. And for our new members, don't worry about anything. So we are going to have clinical chemistry again as a course from the scratch, from zero, from scratch. So we're going to have it. So don't worry about it. So it's just like we are trying to revise and simplify it in order to at least feel confident with clinical chemistry.